Doing it.
All right, welcome to the Corey Jones Show. I'm Corey Jones, CEO of Safety Man Security Consulting, safetyman.co. And you know at Safety Man, we do 3 things to keep you safe. Taser training. Tasers are legal and authorized in New Jersey, Philadelphia, Pennsylvania, New York City. We train you how to use it safely, legally, and tactically. We also do crisis management and active shooter training for any business, hospital, daycare, house of worship, any location for crisis management training so you can stay safe and have a plan. And finally, verbal judo, verbal de-escalation, so we can use words, body language, and tone of voice to hopefully gain voluntary compliance and reduce the likelihood of violence or resistance. So I'm here with Dr. McMillan. You got a lot of letters after your name. I can't remember them all, so I'm going to let you see what they are, but you're the chief of orthopedic, and we're going to talk about opioid-sparing surgery today, among some other things. So welcome, and tell me about yourself, Doc.
Corey, thanks for having me. Again, Sean McMillan. I'm an orthopedic sports medicine specialist in the Cherry Hill and Burlington area. I really focus on young athletes, weekend warriors, like guys like you and I, trying to get us healthy and keep us from getting too hurt. And as you mentioned, I'm the chief of orthopedics in the Willingboro and the Camden campuses for Virtua Health.
Okay. So how did you get into, I'm just going to get right to the meat, because we only got a half hour. And I think this is really, really breaking news for a lot of people that are going to find out about opioid-sparing surgery. So
Opioid-sparing surgery, what it really means is we're essentially finding a way to do our surgery safely and effectively, but make sure that your pain is minimized afterwards without the need for narcotics. Mm-hmm. And really this became a passion of mine and some of my colleagues, simply because we take care of a lot of young athletes. And you hear these stories of kids who had an ACL done, and 6 months later you find out that they're addicted to a medication, or maybe you don't find out about it until it's too late. Mm-hmm. And really what we said was we need to do a self-analysis about what we're doing, mm-hmm. and figure out, can we maybe cut down on the need for narcotics, and if so, how can we take care of the pain so they don't suffer at the same time?
Right, because you kind of got to do both, right? You got to fix the problem and not trade it for another problem.
Yeah, a lot of patients actually, will come to you and they'll have maybe a rotator cuff tear, and you'll say, what took so long? And they'll say, well, I had a neighbor who had this done, and he or she said that it was horrible and they suffered in pain for weeks and months, and I'm afraid. And that's when it opens the door for me to sort of give an explanation that this isn't your father's rotator cuff. This is a new rotator cuff that we're doing, mm-hmm. and we have modalities, and really lay out the steps how we're going to do it. Because it's one part me and 2 parts them as far as the talk track goes, for understanding mm-hmm. what we're going to do to minimize their pain without mm-hmm. need for narcotics.
And how long ago did you decide you're going to do this and get started?
Yeah, so it's been something we thought about probably for the last 4 or 5 years, but it really took hold about 3 years ago, mm-hmm. When a medication came to the forefront for orthopedics and now other specialties called Exparel, which is made by a local company in New Jersey by Pacira. And essentially, when you think about your normal Novocaine that you use on teeth, it's a way of taking a lidocaine or a Novocaine, but making it in a way that it releases in the body over, say, 48 to 72 hours. Mm-hmm. So it's a slow release, and the pain, when it begins to come back after the surgery, is more of a gradual airplane landing. It's not a light bulb going off. Mm-hmm. So the patient can get in front of the pain with ice, with anti-inflammatory meds or Tylenol, and really only need that narcotic med if it gets really bad. Mm-hmm. So it's really nice to change what was something that was devastating maybe even 5 years ago and make it more of a more pleasurable experience while we get them better.
So obviously the feedback has been really good. Are you involved in case studies or tracking all this?
Yeah, so luckily, thank God, we've been able to publish our own data. We kind of put our money where our mouth is. We were the second hospital in the entire country, and the first, obviously, in the state of New Jersey, to offer the Exparel interscalene nerve blocks, which basically makes the arm numb mm-hmm. for those 48 to 72 hours. And we published our data on the first 60 or so patients. And what we found was, in a traditional rotator cuff, where a patient might need 60 to 90 painkillers to get through their recovery, mm-hmm. we were needing about 2 to 3 pills over the same period of time. So we took that number and cut it down to almost 1 or 2%, which was incredible. And we published that data, and we've been lucky enough to present it both locally, nationally, as well as internationally. And I mentioned we presented that in Amsterdam last year.
Right.
So we're getting the word out internationally now. And something that was just a novel idea, maybe 18 to 20 months ago, it's almost a standard of care in almost every hospital and surgery center now in New Jersey and in the surrounding areas.
Yeah, obviously you're busy. People are catching on because I've been trying to get you to come on this show for almost 6 months now, so I appreciate you finally making it. So how many patients have you guys actually been able to help?
Yes, so as far as opioid-sparing surgery goes, we're well into the thousands now. We're over 1,000 cases in the last couple of years that we've done this on. And we've been able to expand it now, not just to shoulders, Corey, but we're doing ACLs, we're doing total knees, we're doing other things like wrist fractures. So if there's a surgery that we're going to be doing something major, we're going to make sure that the patient's comfortable. And again, we'll keep that talk track going. And that's important. And what I mean by talk track is simply, we have a conversation that starts in the office when we book the surgery that says, I'm going to do X, Y, Z to fix your problem. But in addition to that, we're going to take care of your pain. And I'll take the extra 5 minutes to say, we're going to make sure you get this medication to minimize your pain. We're going to make sure we give you Tylenol, ibuprofen, ice machines, things to sort of round out a multimodal approach. And then we took the effort to go back to all of our nurses in the hospital, the recovery room nurses, the intake nurses. Everyone was on the same talk track, understanding and reassuring the patient, listen, what you're going to go through is going to be a pleasurable experience, and here's why. And I think having everyone on board with the same sort of principle is what allows us to execute this.
Yeah, so that's important because if one person gets that wrong, then I'm going to believe that person. So you were saying earlier that a lot of people have fear about even asking you for a surgery, or wanting to get that rotator done or something else. And obviously surgery is probably the right way to go because it's only going to get worse the longer it goes. So how did you get the word out to get people to finally bridge that gap?
Yeah, so honestly, this is something where when you have a good experience, right, what do? You tell 2 of your friends. So and I mentioned those first 60 or so patients that we did the research on. You'd be surprised how many of those patients told 2 of their friends and told 2 of their friends. And then I mentioned we take care of a lot of high schools in the area. And maybe a young athlete had a shoulder surgery done, and that mother, she speaks to 10 other mothers and says, Johnny had his shoulder done, and that mother seeks you out, or for their child, which you should.
Yeah.
And that becomes a big deal. And then obviously things like this, local media, publishing papers, it all becomes this sort of education process.
Yeah, because that's how I heard about you, word of mouth. We have a common colleague that we're friends with, and she was saying the same thing. And I'm like, I need to do that because I'm very passionate, as you know, about with NJ TIP and a treatment incentive program for recovering addicts or people who don't want to get addicted, or they know somebody who is. So that's why I feel it's really important information. So what else would you want the viewers to know about how they would go about getting a hold of you to get something like this?
Yes, so a couple things. The one thing you mentioned there that I think is important is people that are in recovery. It's something that oftentimes we'll see a patient, it'll never come up. Okay, patients may have had a problem in the past, and we'll actually maybe never know till it's too late. But because of our openness and how we share this information with patients, whether or not they are recovery or not, it makes it a lot easier. So I've seen a lot of patients, in particular in the last year or two, that have come to me specifically because they have a problem. They were worried about slipping. Yeah. After surgery, and they're almost happier than could be to be able to verbally say, Doc, I've had a problem. I know you do some stuff that's going to help me. So I think that's really important. And that's something where if you have a colleague or a friend that maybe has a problem, we're happy to talk about that and keep it confidential. So you talked about the best way to get in touch with us. Obviously at Virtua Orthopedics, we have a couple different ways with offices in Cherry Hill as well as offices in Willingboro. We have a main number that's going to be 856-470-9029, as well as I have my own personal website with information about opioid-sparing surgery, which is just www.drshawnmcmillan.com. And again, there's more information on there for patients to read about to understand what they're getting involved in.
All right, so take me through, say I show up as a new patient, take me through how that's going to go from, the first call to eventually when I get sent home with my ice machine and my...
Yeah, so speaking specifically just about surgical patients, I mentioned, if I see you in the office, Corey, we go through a workup, you need something done surgical, we'll go through the scheduling, the booking of the day of the surgery, and then myself in the room with you, we'll go through the opioid sparing approaches. Here's what you can expect. You're going to meet an anesthesiologist that will offer you a nerve block. The medication involved is this. Here's some literature on it, so I give literature out. And then I explain the other medications that are non-narcotic that we'll give. Then you'll leave my room where I'm examining you. You'll meet my surgery scheduler. And she's fantastic, Janet. And she'll actually go through booking the surgery, arranging the ice machine. Regardless of the insurance companies, we really work hard to make sure that if the insurance doesn't cover it, we get it for you, or get most of it covered. And that's been a really great thing that a lot of the local areas, a lot of vendors have helped us with.
Yeah.
She'll take care of the ice machine. She'll again reiterate your pain's going to be under control. When you go to the hospital for pre-admission testing, the nurses there, they're thrilled to be able to offer this. They really are proud of it. So the nurses will go through what to expect the day of. And again, here's the nerve block. Here's the medications that Dr. McMillan writes for. Day of surgery, same thing. I say, how you doing, Corey? Check you out. Same talk track from me, my anesthesiologist, my nurses. During the holding area, when you get the nerve block, everyone reiterates the same principle. So we're all on the same page, and then you get that one more time at discharge with instructions on when to use the medication, not just you're getting medication, but when to utilize it, how to utilize it, what do you do if the non-narcotic meds don't work. All these things are important because just like giving someone training, if you don't know how to use it properly, it's worthless.
Yeah. Yeah, so that's really encouraging to me that you're able to get all that information into somebody, help them, and then send them away without fear. Because to me, fear is one of the most powerful motivators in the world, to either to do something or to not do something. And so you kind of are operating on both sides of it. You're taking the fear away so they can get help, and you're also taking the fear away so they don't slip or get addicted to something that they.
It's empowerment, right? We talk about the word empowerment a lot. Patients need to realize that they have a say in their surgery and their recovery. And when you go to a doctor, and I say this family, I say this to my own mother, if the doctor doesn't want to take the time to explain to you what they're doing and why, and explain what we're going to do to take care of you, there's a lot of doctors out there, right? And so you got to make sure that you find the doctor that's going to meet your needs. You should never be intimidated to ask a doctor a question, or if you don't get the answer that you were looking for, to say, can you explain that a little more clear? Because I think understanding leads to empowerment, which leads to patients taking hold of their recovery, and it leads to better outcomes.
Yeah, that's super important. Like sitting here today talking to you,
Right.
I've learned so much. And, I know a lot of people that have, different injuries and stuff like that, and it's almost silly to not go get it taken care of, especially when you have this alternative to that, because everybody's afraid of, they don't know, am I going to be addicted to this or not? And you're giving them those options. So can you talk to me a little bit about how you're doing that medication stacking? And you've obviously, did you have to doctor that?
Yeah, so a lot of it's actually in the literature, and it's been adopted universally, by many surgeons. But we'll use a combination of medicines that target both the brain, the soft tissues, the muscle, as well as your pain receptors. So acetaminophen, probably one of the oldest medicines we've had around, or Tylenol, we'll actually go to a higher dose for a couple days, up to about 1,000 milligrams every 6 to 8 hours. We're going to use the ibuprofen, and we're going to say, let's work it in between the acetaminophen. So that way you're getting something maybe every 4 to 6 hours that's different. So you're constantly taking something when you need it. With the ice machine, we'll start even when the nerve or even when the shoulder or the knee is numb still. We'll get the swelling out right away. And then we do lots of things intraoperatively to minimize bleeding and swelling and things of that nature. So we really make sure that the patient knows on a schedule, start with this medication, move to this medication. If, God forbid, the pain's too great, you do have your other medication available, but let's hold off on that until you really need it, and really do a self-reflection and say, where's my pain at right now?
So you talked earlier about how the pain is a gradual coming back as opposed to like waking you up in the middle of the night with a stabbing pain. Can you talk about that?
Yes, so traditional surgeries and traditional nerve blocks, the Novocaine would wear off. It would almost be like you sat on your foot and it starts to wake back up. You feel those pins and needles, and then, oh my goodness, it's that rush. So the medication now, because of the way it's formulated, it becomes something where it's this gradual sort of awakening, okay? Almost like you're getting up in the morning and stretching. So you know it's coming, and we tell patients, when you feel that start to kick in, that's when you want to start with your first non-narcotic medicine, your Tylenol. Then you want to add in maybe your Motrin 800 if you're able to take something like that, or your aspirin. The ice machine should be going 24/7 before that. And because the block lasts a little longer than what we're used to, we have to let patients know, listen, if you can't move your arm for the first day or so, nothing went wrong. It means the medication's working really, really good, because that's scary also.
Yeah.
But I think understanding something called the pain storm, which we talk about a lot in orthopedics, which is the first 72 hours after a surgery is when the pain is at its height and begins to recede. If we could find a way to get a patient through those first 72 hours, minimizing the need for opioids, the rest of it becomes gravy. And I'll tell you, if a patient can get through those first 3 or 4 days not reaching for the opioids, the studies show that they're not going to reach for it on day 4, day 5, day 6. So we've accomplished our goal. And by minimizing the number of narcotics we write for at time zero, meaning the surgery, we were able to avoid having pills left in the closet behind for maybe a small kid or someone else to take down the road. So we're eliminating the need for excess narcotics on the street or in our homes.
That's great. We got to pause for a commercial break right now. We'll be right back. Stay here.
I want to be a contender. I want a warm belly to sleep on.
A big house.
How do I look? Do I look good?
I want to play hard.
My nails done once a month.
I want.
I want a home. I just want a home. I want someone to love.
Last year, more than 30,000 companion animals came to us without homes. 20,000 of them were felines. Let's make some homes together.
Hello everyone, I'm Mark Iorio. I'm the host of Rainmakers Roundup right here on RVN TV. The show is about looking for people who are in competitive businesses that are doing something different and unique in the world of sales and marketing. Join me right here on Rainmakers Roundup on Wednesday mornings at 9 a.m. and then again on Thursday evenings at 6:30 p.m. right here on RVN TV.
Today's show is sponsored by Dr. Jacqueline. Take charge of your life personally, financially, and professionally. Visit drjacqueline.com to book an appointment today.
The session that we had with BCAT was really entertaining and enlightening. We were able to put together some very specific steps that we as individuals can take, and it was really fun to all come together and see sort of where we're going as a team and how we can all get there together.
We had a tremendous experience with the BCAT partners. One of the challenges that we have as an organization is to make sure that we have the right people in the right chairs doing the right thing. To do that well, you have to have synergy. You can try to dream up ways to make sure that your group does that, or you can rely on experts. We would recommend BCAT partners to anybody who's looking to take their organization to the next level.
All right, welcome back to the Corey Jones Show. I just have a fantastic guest here, Dr. Sean McMillan, and we're talking about opioid-sparing surgery. And before we left for a break, we're talking about the pain as it comes back after the surgery. Can you talk about that, please?
Yeah, so again, we talk about the pain storm, which again is the first 72 hours after a surgery. And what happens is you start to feel pain in a couple different levels. You'll feel it locally, where we made the incision. You're going to feel it deep within the musculature if we're affecting the bone or the tendons. And then you start to feel it cerebrally. You're going to feel it at the brain level, where the brain responds to different stimuli. So we try to target different areas with medications like Tylenol, the Motrins, Lyrica or gabapentin to sort of dissuade the nerves from feeling some of the things that they're used to feeling. And that allows them to calm back down, almost like you're letting a Charlie horse settle. And if you can get that to calm back down and become more of a stable setting, you know, you've given a bottle to a crying baby, so to speak. The baby calms down, everyone, you know, drops their energy level down a little bit, and that's what we do with the pain. And then from there, it begins to become a lot more of a smooth sailing, because we know this as well. The sooner you're feeling better, you resume your normal life activities. being around people, getting out of the house, keeping your mind occupied will again make you not think about the pain as much.
Right.
And we'll find patients will say it hurts the most at the end of the day when I'm going to bed. That's because you lose some of that white noise that you have during the day.
And you're able to focus on the pain now.
Yep, so we get you back to living life a little bit quicker, and then a lot of that goes away.
And then I guess your patients also have to go to rehabilitation after that?
Yep. So we'll start physical therapy. We work with a lot of great places in the area, and really we've spent a lot of time actually lecturing and teaching, educating our local physical therapy companies. I've probably done about 8 or 9 talks in the area, letting the therapists know what we do, how the medicine works, why it works. So it becomes a two-way street. One therapist will maybe send us a patient that might need surgery, but 2, they understand what the patient's going through after the surgery. So they'll modify some of their early on interventions with the patient, and really that becomes a nice conduit because the therapist is reinforcing what we taught and what we're preaching because now everyone's buying into the same story.
Right. And so that's got to be so much more successful. I'm just thinking, like, 25 years of being a police officer and dealing with people that were struggling with addiction, you find that a lot of people started because of a prescription that they were given, as opposed to just finding it on the street. Not most, I don't know what the actual numbers are, but we unfortunately had that a lot. So, and like, I know you said that's kind of what motivated you.
Yep.
Yeah.
So when you look at some of the literature that's out there, I'm an orthopedic surgeon, and as a sports surgeon, a lot of what I do is elective, meaning you hurt yourself playing basketball with your friends or your family. I treat you, I get you back to living your life, and that's what we want. But what we found was actually up to 13 to 14% of patients that were opioid naive, meaning never were on opioids prior to a rotator cuff or say a total knee. They came in, they had their surgery done, and they ended up opioid dependent, meaning they were still taking opioids 3 months or more after the surgery. And in a lot of ways, I feel responsible for that because those are my patients. I was supposed to deliver them a good surgery and also protect them. And if we don't ask the questions, are you still taking your pain medications? Have you tried this? Have you tried that? When we see them for follow-up visits, we're almost negligent. So I want to make sure that we're all on the same page and we're diligent to make sure that we're asking the right questions. If a patient needs intervention, we'll make sure we can find a way to find other modalities, injections, whatever it might be, to minimize their pain, get them off those meds.
So again, is there a success rate that you're able to talk about or that you're aware of?
Yeah, I mean, nothing's perfect, right? If it was, we'd all live on an island somewhere. But I'd say, by and large, we're somewhere around 80 to 90% of our patients are using 10 pills or less when it comes to a rotator cuff surgery. And when we say pills, I mean opioid pills. With our total knees, we have patients, again, getting off opioids within the first probably 7 to 10 days, if not sooner. And they're going home quicker. So you're not going to rehabs for 10 to 14 days anymore. And again, with COVID, no one wants to go to a rehab center. They want to go home. So we're doing things intraoperatively to minimize their pain, get them up and moving around that day in the recovery room from their knee replacements, and then getting them home. So that protects their overall health as well as their potential for opioid dependency.
So the opioid sparing is part of it, but you're actually doing the surgeries somewhat different too to help minimize like the ancillary damage and so forth?
Yeah, so again, as much as we go through medical school, we're constantly learning, right? So whether it's the way we handle the soft tissues, the muscles, the skin during the surgery to minimize trauma to it, minimizing bleeding, which is a huge source of pain, using different medications intraoperatively, powders and other medications like that. These are all things that maybe we took for granted 2, 3, 4 years ago. And now we're realizing it's multifactorial as we pull each of these parts together to say, how can I give Corey the best surgery safely, quickly, and get them home safe and minimize all the complications that can occur around it.
That's just incredible information, and I hope our viewers are taking this down and thinking about anybody, your friends, family, coworkers that could benefit from this. So one more time, Doctor, can you tell our viewers how they can get a hold of you and where they can get information to educate? So
again, our offices with Virtua Orthopedics are located in Cherry Hill in Burlington. We have a main number that'll allow you to get to myself and my partners at 856-470-9029. And if you want more information, particularly about the opioid sparing approach that we take, www.drshawnmcmillan.com would be the website to go to.
Okay, so you talked about rotator, total knee. Are there any other issues that you guys take care of?
Yeah, so as an orthopedic sports surgeon, I specialize in minimally invasive surgery, meaning small poke holes, to fix problems with the rotator cuff or the shoulder, the hip, the knee, the ACLs, We're blessed and lucky enough to take care of the military here in the area. So we see a lot of young athletes, and we're getting them back quicker and safer to protect us and do the job they love, which is something that I feel gracious to be a part of. And then a lot of young athletes, high schools and colleges in the area. So really, if it's a sports-related injury, we're there for you. We're taking care of you, and we're able to meet all your needs at Virtua Orthopedics.
That sounds awesome. I'm a Virtua client, I guess you'd call it. So I always have been. I was born, wasn't called Virtua then when I was born 49 years ago. Memorial Mount Holly. But yeah, they're a great healthcare system. So one more time, just take me through that process of how I can get started with you if I have an issue, and then walking me through those steps again. I just want everybody to be really clear on this.
So we're a team approach, and one of the things that we prided ourselves on, and again, this goes back to my own personal experience with my mother. When I was growing up, she was had some medical issues, and we went to lots of doctors. And I noticed the one she felt most comfortable at was where she felt comfortable with the entire staff. So we take that approach. We individualize our care to the patient to find out what their goals are and how we can get them there. So in our office, you'll start out either meeting myself or one of my physician assistants who will get you worked up. They'll get the right imaging, the x-rays, the MRIs, and then make sure you get to me if it's not right away. And then we're going to come up with every option, non-surgical, surgical, combination thereof, to say what's going to get you back doing what you want quickest and not affect your life, because I get people need to work, live, take care of their family members.
Right.
Once we start that process, Corey, if it's surgical, we're going to make sure that we design a plan that's going to minimize the need for pain and opioids afterwards, but also let the patient know we're not going to leave them hanging. Opioid sparing doesn't not mean that we're opioid naive or opioid remiss. We're going to make sure if you have pain, you get the meds you need, but we're going to find a way to minimize the need for those meds, and we're going to find other modalities to keep you comfortable.
It must be a sliding scale, because you alluded to the fact before that you get a call on a weekend or from one of your patients who needs pain, and even things like that have gone down?
Yes, so I can tell you when we changed medications and we started using the Exparil nerve blocks and this multimodal approach, I operate on Fridays. So my partners that were taking call on the weekends started noticing that, hey, I'm getting less phone calls on Saturday and Sunday from Mr. and Mrs. Jones who had surgery Friday.
Right.
And they became curious, and then they adopted these habits, and it became this growing sort of phenomenon. So really, if a patient does call and they're having issues, we can walk them through our escape plan B, C, D, and E to make sure that they're comfortable. And if we need to find more meds, we will. But most times we can find a way to say, maybe let's switch the regimen of meds that you're taking around and see if we can find a way to make your pain a lot better.
So they rate their scale like what pain they are before they get there, their immediate pain after the surgery, and then do you have them rate their pain?
We do. Oftentimes I'll say, scale 1 to 10, what are you feeling right now? Because when a patient calls, the first thing they know is I'm in pain. And I want to respect that. And I want to say, all right, is this like 10 out of 10, like it's worst pain of your life? Is it a toothache? Where are we at? Because that's going to guide me as far as how I want to tailor the medications to them. And oftentimes when you ask the question, are you elevating? Are you using the ice machine? Have you tried X, Y, Z? You'll hear they haven't yet, or maybe they're doing it incorrectly. And we can just correct that right on the fly and then make sure that they're comfortable again. But we never leave them hanging. We'll oftentimes follow up a couple hours later. How you doing, Corey? Did it get any better? If we have to meet you in the emergency room, we will. But I can tell you the number of readmissions, which I thought was really telling, patients going back to the hospital over the weekend because they needed more medications, is next to zero in the last 3 years for us. Because we're able to meet the needs that they have and then be able to coach them over the phone, very much like verbal judo, to coach them the right ways to manage their pain and make sure the talk track, whoever answers the phone on the weekend, knows exactly what we're going to say back.
That's incredible. And I love that you take the holistic approach. Dr. Sean, Virtua Chief of Orthopedics, right?
That's correct.
At Willingboro and Camden. If you need help, go to SeanMcMillan.com.
Yep, www.drseanmcmillan.com.
And stay safe, stay healthy, and be ready.